Welcome to this show discussing problems and issues of health with Dr. Alcena. For this segment of this show, I'm going to continue to talk about hypertension. I've done 7 half-hour shows so far in this series. In this segment, I'm going to begin to the process of evaluating patients so they can be treated for hypertension. In the process of evaluation, I just want you to be aware that this is 2 forms that I set up in my office myself. No one anywhere else, I'm sure, have this type of form. This form here, this is the laboratory form, has a little bit more than 200 tests, different tests that one can use to diagnose different diseases in patients here in the United States and across the world. The same thing happened. This is the radiology, EKG type, cardiology type form. There are a little bit more than 100 different tests one can do here between radiological tests, cardiology tests, etc., to evaluate patients with different diseases, of course, including hypertension. One of the most crucial things in evaluating a patient with hypertension, you have to take a history. Very, very important to take the history from the patient, and you have to ask the family history, the marital history, the habitual history. Does the patient smoke? Do they abuse alcohol, etc.? The past medical history is crucial. Have they had a stroke in the past? Have they had a heart attack, etc.? Have they had any kidney problems? And of course, you take the symptom that they're having chest pain, headache, shortness of breath, etc. Take a very long history, allergy histories, and so on. And then you're going to proceed to do a thorough, complete examination of the patient, which include from the head all the way down to the toe, to do a complete, thorough physical exam. What are you looking for? Well, part of the, of course, exam, you're going to take the patient's blood pressure. You can take the patient's pulse. Is the pulse regular? Is it irregular? Is it strong? Is it weak? When you're taking the blood pressure, you're going to take the blood pressure while the patient is sitting down, standing, very important. The sizes of the different cuff that you're going to use to take the blood pressure is crucial. If the patient is very small, you have to use a small blood pressure cuff. If the patient is medium size, you have to use a medium size blood pressure cuff. If the patient is obese, you have to use a large blood pressure cuff. If the patient is excessively obese, then you have to use a jumbo blood pressure cuff. I have all different sizes of cuff like that in my office. Why is that important? It's important because if the patient is very small and you take the blood pressure with a larger cuff, it's going to make blood pressure falsely low. If the patient is very heavy, a large arm person, you take the blood pressure with a small cuff, it's going to make blood pressure falsely high, almost by 10 millimeters of mercury. Those are crucial things. If the patient elderly, then you must take the blood pressure in both arms. Why is that important? It's important because the patient is likely to have occlusion in different arteries. So if one of the arteries or 2 arteries are occluded, people talk about arterial occlusion. When you have arterial occlusion, it's not just around the heart. It could be around the brain, around the heart, down the leg and the arm, inside the abdomen, etc. So if the patient have an occluded artery, and you take the blood pressure in that arm, that blood pressure is going to be falsely low in the arm where the artery is occluded. So therefore, you must take the blood pressure in both arms, if the patient is elderly. Those are very crucial points to remember. Now that you take the blood pressure, you finish your examination, then you're going to begin to do some laboratory evaluation. Crucial. You're going to do a complete blood count, which is right over there. Complete blood count over here. Right here. Let me put my glasses on. You're going to check that off. You're going to do a complete blood count. It's right here, CBC. If the patient is diabetic, you're going to do A1C right here. Then you're going to do a complete metabolic profile. That's all the blood chemistry. You're going to do a T4, TSH to evaluate the thyroid status. Urine analysis, urine culture if you think that's necessary. Then you're going to be a lipid profile. That lipid profile covers, complete lipid profile covers triglyceride, total cholesterol, HDL, LDL, etc. And then over here, you're going to do serum ferritin to check the patient iron status, crucial. Then you're going over here and do a vitamin D right here, very, very important to do that. And in addition to that, if the patient in question is a Negro slash African American slash, you're going to do hemoglobin electrophoresis right here. You must do that. And I'll tell you the meaning of that. You do hemoglobin electrophoresis. Right up front. You do all these things right up front because you're meeting the patient for the first time. It's the first time you're seeing this patient. You're evaluating. Those are the basic tests that you're going to do. In addition to that, depending on the ethnicity of the patient, where the patient comes from, you're going to try to get yourself a lipoprotein A. Yeah, you do a lipoprotein A. You could do a homocysteine. Why is the lipoprotein A important? Well, this is where knowing who your patients are, where they come from is very important. In my office, the vast majority of Negro patients have elevated lipoprotein A. In particular, my patients who are from the Caribbean, in particular Jamaica, have elevated lipoprotein A. And if it is a man, and that's crucial, 20% overall of the U.S. population have elevated lipoprotein A. But in my office, between 75 to 80 patients of my Negro patients have elevated lipoprotein A, which is crucial, absolutely crucial in modern medicine. Okay? Crucial. When I mean crucial, I mean absolutely crucial. And I'll get to that at another time. And this is the beginning. And if the patient, she's a woman, she has been pregnant, either she has children or she lost the fetus, you must do this test right here. You have to check that. You have to do it right here. I'm looking, let me put my glasses on. Okay. There you go. The glasses is on now. You definitely, to make sure the patient did not have anti-hydrolipin antibody. Because the anti-hydrolipin antibody, the fetus, the mother develops an antibody against the fetus. The fetus becomes an antibody, the antigen. Well, why is that? For the rest of her life, she's exposed to clot. She can clot, absolutely. Why is that important? Well, women are becoming menopausal. Once they become menopausal, now they have ability to go over the counter and buy a series of estrogen-containing medication on their own. Sometimes it is prescribed for them. They can clot like that because they have antiphospholipid antibody, because they had one single pregnancy. That's all they require. Significant percentage of these women will develop that. You must do these things. If you're going to take the responsibility to take care of these patients, they're your patient. You're going to provide primary care for them. Because primary care, general internal medicine, is the heart and soul of the field of medicine. That's correct. The heart and soul in the field of medicine. So you must have all this baseline thing so that when things happen to your patients, they show up in the emergency room or they call you in the middle of the night, you have the high suspicion what could be going on with them. You can't justify, absolutely cannot justify taking care of a patient and don't check the B12. You have to check the B12. The B12 is right here. See, it's on the form. You check it off. You absolutely cannot justify not check a patient vitamin D. It is crucial. You tell me, when we went to school, myself included, when I was in training, B12 is something that we talk about pernicious anemia. That's what we were taught, that you become, the red flag goes up when somebody become anemic and the red cell become very large. Therefore, you suspect they may have B12 deficiency because they have macrocytosis. This is true, but guess what? This is the absolute last step in the B12 deficiency syndrome, because you have, all of us have 500, of adults have 5,000 microgram of B12 in our body, and we lose 0.05 milligram per day. So it takes 10 years, literally, to eliminate your B12 levels so that the anemia will show up. But what you have to understand, the B12 deficiency syndrome, the minute you begin to lose B12 for thousands of different reasons that can happen, literally. Then you have problems. And one of the key problems is the fact all nerves in the human body are covered by myelin sheath, a substance that's a myelin sheath covers the nerves. As you begin to develop B12 deficiency, the level of B12 start going down, your myelin, those things that cover the nerve begin to degenerate. That's exactly correct. As the myelin sheath begin to degenerate, you're exposing the nerve. That's where all the tingling, the numbness, the memory loss, etc. begin to kick in. The vast majority of the individuals who have memory problem because they have B12 deficiency and or thyroid deficiency, hypothyroidism. Let me repeat that. Because for a variety of reasons, not only because they're eating a poor diet, also they're not absorbing the B12. It has nothing to do with pernicious anemia. Atrophic gastritis, meaning that the blood flow to the area of the stomach where you need to absorb B12 is deficient. So atrophic gastritis is one of the leading causes of B12 deficiency in the elderly. If you don't know this thing, then you have to ask people who know it to help you to manage this individual. On top of that, to make matters worse, the whole B12 absorption process began in the mouth. You say, but how so? Well, we have salivary gland. You can't make this up. When you chew the food that has B12 in it, the salivary gland begin the process of decomplexing the B12 that you are chewing that you're going to swallow. That's the first step, okay? But as you get older, your B12, your salivary gland started drying out. That's right. All of us, myself included, as you get older, your salivary gland begin to dry it out. That's why I give myself a B12 shot every month. That's exactly correct. I myself give my own self a B12 injection every month because I'm getting older. And I'm smart enough to know that I'm going to become B12 deficient the older I get. You understand that? So failure to comprehend this stuff. It is not the fault, frankly, of most of the physicians. They were never taught that stuff because the people who taught them didn't know this stuff themselves. This is modern medicine. You have to understand something. I went to one of the top 25 medical schools in the United States, Albert Einstein College of Medicine. And I went to one of the top training programs in the United States, Montefiore Hospital. And yet, let me repeat that, and yet 80% thereabout of what I do every single day in the practice of medicine, I taught myself. This is not to say anything negative about my school or my training program. This is the reality. And they taught me fantastically well. They trained me extremely well, but that's years ago. I graduated in 1973. I finished my training at Monty in 1978. Okay? So if I were to sit there in my laurel and say, oh my God, I went to Einstein, I went to a great school, I went to a Montefiore, a great training, which they are, and don't study, don't keep up to date, I won't be able to sit here and telling you these things because I did not learn them at Montefiore. Nothing wrong with Montefiore. It's a fantastic hospital, great training program. But that is the reality of it. So you got to keep up. I know it's hard. Believe me, it is absolutely difficult. Because when you are practicing medicine, you're working so hard, 24/7, dealing with all sorts of different harassment, all sorts of difficult problems. When you get home, you are flat out exhausted. And people have children to take care of them when they get home. It is a major commitment to expect them to grab a journal when they're exhausted. And they're getting up at 4:30 in the morning to get started all over again. On weekend, I'm not making excuses for them, but I'm explaining to you it is not easy. And you have some fantastic, outstanding physicians out there, those who have made the commitment to continue. This is why you go and look at the AMA website. There's now a new phenomenon, physician burnout. That's right, a big time new phenomena that's been identified in the last few years, physician burnout. These folks are burning out. Some of them are quitting. It's not easy. But me, medicine is not only my profession, frankly, it is my hobby. That is all that I do. Other than doing a little cooking every now and again, once or twice a week, this is all I do, okay? All right, that's that. So when I talk the way I talk, I'm not blaming anyone. I'm just telling you what I do. That's my commitment. That's what I've decided to do. That's my role. But I know what my colleagues are going through. It's hard. There's nothing easy about the field of medicine. There's nothing easy about it is rough. It is tough and getting tougher. It's getting tougher. Okay? So the point is now, why do I go to all this blood pressure thing? Because if you have these other conditions and you also have hypertension, we need to know, because we have to incorporate the treatments of all these other conditions in your treatment of hypertension. So when we do all these blood tests, we do the lipoprotein A, depending, we know where you come from. We're not discriminating against you. We practice quality medicine. We do the homocysteine. We do the antiphospholipid antibody in the female. Those are the basic, my friend. There's at least 12, 14 different thrombophilias on the form here that I could have checked, but I checked those basic ones, okay? All right? And depending if the patient is complaining of joint pains, which they often do, well, you do a sedate to make sure they don't have some sort of bizarre disease that hasn't been diagnosed. They don't have rheumatoid arthritis that haven't been diagnosed. They don't have scleroderma that haven't been diagnosed. So if you go and throw in the sedate, well, you go ahead and check off the ANA as well. Because if the ANA is positive, then you open a new world of possible rheumatological diseases that can affect the patient. The same thing, the sedate comes back elevated. You cannot have a chronic inflammatory disease or chronic infection anywhere in your body and has a normal sedate. There you go, okay? And there's nothing wrong to throw in, because nowadays when we order the complete metabolic profile, they don't do the LDH. You sneak the LDH in there. It's there separately. I have it separately. Why is the LDH crucial? Because, let me repeat that, because you cannot have long-list certain cancers without having an elevated LDH. So like I said to you, for every doors, for all doors, there are keys to open them. Right here, I have lots and lots of keys, dozens of keys here that can eliminate dozens of different diseases by just one simple click. And as you're talking to the patient, when I'm sitting there to take a history from my patient, the forms are right next to me. Before as a matter of fact, a lot of the time before I even examine the patient, I'm checking things off based on what you have to learn. Let the patient speak. Let the patient, don't stalk the patient. They're telling you, basically, if you know how to listen, the patient is making the diagnosis for you by telling you what's wrong with them. You just have to listen. Don't cut them off. Listen carefully. And then when you finish listening, then you ask your question. Because the key thing is the patient that's telling you what's wrong. And if you know how to listen, you know enough about high quality clinical medicine in the 21st century. She's telling you what's wrong. She's telling you the diagnosis. You have to listen carefully. And then you know what specific to ask her based on what she tells you to confirm it. A lot of the time, I would say before the patient leaves the room, 80% of the time, I already figure out the diagnosis. Even before I do any tests, I already figure it out. 75 to 80% of the time, before I walk out of that room, I already know what the diagnosis is. Okay? And then you send the test to confirm them. That's all. You can't let the test diagnose for you. That doesn't make any sense. The test is to confirm what you suspect is wrong with the patient. Okay? Then, of course, when you examine the patient, based on your finding on examination, that's important as well. Then that can further solidify for you what is you think is wrong with the patient. Okay? So and then when you do that, you check off what's what. You go over here on the radiological section, you're going to do a chest x-ray. you're going to order an EKG, obviously. And if the blood pressure was elevated while you examine the patient, while at the same time you're going to do an echocardiogram. Why wait later? Because you want to know the size of the heart, how the heart is functioning, what the EF is. Right away, when you're sending the patient over, you check your chest x-ray, you must do. You do an EKG. If you don't do it in your office, send it wherever it gets done. I don't do that in my office anymore. Then you check off an electrocardiogram. And if the patient is complaining of symptom that's consistent with angina, right there, you order a stress test at the same time. Simple as that, okay? And you could do also, like I said, there's 100 different radiological pulmonary tests, x-ray tests. I put all this form together myself over the years. And every now and again, I add more to it. Okay, so now you wait for those results to come back. However, if the blood pressure is abnormal, you can't wait for these things to come back to start treating it. How about that, okay? That's when the treatment begins. You could modify the treatment later, but you can't wait to get all this stuff back in a week or two to begin to treat it. So this is where we come to the different stages of blood pressure. You have stage 1, you have stage 2, stage 3, and stage 4. Stage 5 is usually hypertensive crisis that the person will rush in the emergency room with blood pressure sky high, can barely stand up, about to have a stroke, blah, blah, blah. We have to step in. This stupid, very important thing we have to do in the ER quickly to prevent the stroke from developing, and very carefully lower the pressure over several hours to prevent the patient from bleeding into the brain. That's crucial. I've done that hundreds of times. However, in your office, somebody, let's say, comes in, they have a blood pressure 140/90. That's classified in the book, even in this book, as stage 2. So right away, because stage 1 is anywhere between 130/80, 85, so on and so forth. And lately, they try to modify them a little bit to make them prettier. But I don't practice pretty medicine. I practice quality medicine. So 140/90, patient is diabetic. That's crucial. Patient has sickle cell disease based on the issue. That's crucial. Why is that? Because if the patient has other associated diseases, cardiovascular diseases, then you need to step in to treat the pressure even at a lower stage than later. Let's say somebody has sickle cell disease. Well, you can't have sickle cell disease, don't have brain problem. Can't have sickle cell disease, don't ultimately having cardiac problem. Can't have sickle cell disease without ultimately having kidney problem. So step in right away. You don't want to wait until you got the result. You have to step right in, begin to treat the 140/90. Patient is diabetic. Of course, that's crucial. Patient has high cholesterol. That's crucial. If you don't want to wait, you have to step right in. 140/90, that's crucial. For somebody who don't have any of this disease, you can say, well, let's try a little diet here, cut the salt, decrease the weight, blah, 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 and I'll see you in a couple of weeks. You can't do that on someone who's diabetic. Can't do that in somebody with high cholesterol. For that matter, you can't do that in somebody who's obesity, because obesity is a serious medical problem. There's nothing aesthetic about obesity. You should not ever have anything negative to say about someone. This is a disease. Obesity is a serious medical disease. As a matter of fact, this is going to shake your leg. The number 1 cause of cirrhosis of the liver in the world is what? Obesity. How about that? As bad as alcoholism is, as bad of the hepatitis are, they're way below as an incidence, the causation of cirrhosis of the liver. Obesity is number 1. Because when you are obese, you are constantly infiltrating the liver with fat cells, because the body was not made to tolerate that amount of fat. The rest of it has no place to go. It's infiltrates the liver. The infiltration of the liver causes local inflammatory process to develop. Bingo, cirrhosis begin to step in. How about that? So this individual who has blood pressure of 140/90, as my first step, that's the step where I begin to treat. I figure out what underlying problem he or she may have. Then the first medication is going to be a thiazide water pill. That's right, because the number 1 cause of essential hypertension is salt retention. Your first step is to give the patient, he or she, a prescription for, tell them about the diet, tell them to cut back on the salt. The average Negro person in this country consume 7 grams of salt per day, which is ridiculous. The recommended is 2.5 grams salt. Well, black folks eat a lot of salt because of the cultural diet is cultural on one sense. On the other hand, they eat what they can afford because of poverty. All this fast food is basically loaded with fat and salt and spice. So salt is the key. By giving them a water pill, thiazide water pill, you have thiazide, 37.5/25, 1 capsule a day, or you have moduretic, 5/50, 1 tablet a day, or plain old-fashioned hydrochlorothiazide, 25 milligram, depending on the size of the person, or 50 milligram. The reason why you give the combination is because you protect the loss of potassium. And then tell them about the diet. Then next week you'll see the patient. If the blood pressure comes down on that, they're modifying the diet, that's good enough. That's step number 1. That's good enough to treat this patient hypertension. If the blood pressure keeps going higher, then comes the ethnicity issue, which is very, very crucial. Okay? Because the hydrochlorothiazide, that's universal. Everyone who has functioning kidneys, who have hypertension, stage 1, you ought to give them a water pill. Even if they have stage 2 or stage 3, you must give them a water pill. And then you will add the second or the third. The controversy, as it relates to ethnicity, comes when the second or the third medication comes into play. Prior to that, everybody must get that water pill. I know that patients don't like running to the bathroom too often to urinate, but how is the salt going to come out of your system? You can't vomit the salt. You can't sneeze the salt. You can't pack the salt in your stool. The only way you can get rid of the salt is to urinate it out. And the only medication that's more effective is not the Lasix of the world. Okay, it's not a Bumac of the world. They're fine, but that's not for hypertension. You have to give them a thiazide water pill to block the reabsorption of sodium in the distal convoluted tubule so that the sodium gets passed out into the urine and the water follows. That's the way it goes. That's it. Like it or not, that's it. You must use that first. And then you add the second or the third medication, which I'll begin to talk about next week. Until such time, keep watching the show. This is Dr. Alcena saying so long and bye-bye.